Hi, everybody. I am Rosalind Ryan, and I am the newest co-chair to the Genomics Committee. And what we decided we would do, because this is such a large and varied area of medicine, of healthcare, we decided that we would take the next few meetings to introduce you to some of the people that are actually using genomics in their work and have them speak with you a little bit about what it is they do and how this has such a dramatic effect on healthcare. So I have, just as background, a lot of experience in the genomic space in terms of helping people get that into standard medical practice. I was actually a number of committees that I'd attended and been in charge of. I've testified before the House and Senate. I have worked with the government on genomic privacy issues and wanted to bring you some of the best of the people that I've seen that work in this space to just kind of give us an overview. And then after that, we will start having some discussions on what we'd like this group to do in the future and the different other kinds of things we'd want to discuss and create and submit under the WEDI banner. So I'm going to introduce you to a man that I just met recently. He has a company that he works for that does pharmacogenomics, which I will let him explain all those things. I saw his presentation a few weeks ago and was completely impressed by it and thought there's so much good knowledge. I really wanted to share it with some other people. So we've set up this meeting for him to give you background on this. He'll introduce himself. He'll tell you about different ways that they're using it in practice, and we'll give you a chance to answer any questions that you might like. So Dan, the floor is yours.
All right. Well, thank you, Rosalind. Thank you for hosting this and inviting everyone and giving me the platform to speak here. I appreciate it. So this is me, everyone. My name is Dan Dowd. I'm a pharmacist by training. I spent I'm not a geneticist. I'm a pharmacist, but the field of pharmacogenetics is largely getting owned by pharmacists. It marries that that pharmacology with the genetic profile. I spent the first half of my career in the retail pharmacy management world. Did a lot of clinical training. Anyone who lives in New York or New Jersey probably has received a vaccine from some pharmacists that I've trained. I also taught pharmacology in the nursing program at CUNY for 13 years, and currently I work for Genomind. And Genomind, I've been here for almost 8 years actually. It's a pharmacogenetic testing company. Well, really, we started off as a pharmacogenetic testing company, and as we've added more products and services, now we call ourselves now a precision medicine company. So you can see some links to some of my publications. This slide's a little dated. I think I have to add 2 more publications in there. But if you're interested, I'm sure Rosalind will send out these slides and you can read all about it. So that's me. If you have questions during the presentation, feel free to put it in the chat or unmute yourself and ask the question. If I feel like we're starting to get derailed, I'll just ask everyone to hold questions till the end, but we'll see how it goes. So we're going to talk now. Actually, let me minimize my screen here so I can actually see my slides. Okay, so we're going to talk now a little bit about pharmacogenetic testing. So the bare bones of what it is. And I probably don't need to mention what I'm about to mention, but I'm going to say it anyway because there's often there's a misnomer of what pharmacogenetic testing is. So, everyone knows about 23andMe and Ancestry and stuff like that. Pharmacogenetic testing is very different than than what these other sort of recreational labs or diagnostic labs do. So nothing we do in pharmacogenetics is designed to be diagnostic. There is no depression gene, there is no bipolar gene, there is no ADHD gene. Yes, those things are very heritable, but we can't point to any single gene and say, hey, you have ADHD. We will at some point be able to look at thousands of genes and say, hey, you have a 80% increased risk of ADHD or bipolar or schizophrenia, because some of these conditions are very heritable. We probably won't be able to do that with anxiety and depression, because those conditions are very less heritable, but schizophrenia, ADHD, and bipolar is a strong genetic influence there. So nothing we do is diagnostic. What it is intended to do is identify genes that influence drug response, and that's it. So we know that certain genes will influence how you metabolize medications. That can influence dosing of medications. We know some genes influence sensitivity to medications outside of your blood levels. And knowing this information ahead of time, you can personalize your dose, or you can select a medication that's safer than one that has some genetic risk profile. So that's what we're trying to do here with PGX, pharmacogenetic testing. It is one tool of many tools that we use when we're prescribing medications. This is important because I also think unfortunately, many labs have misrepresented what pharmacogenetics can do and have failed to tell you what the limitations are. So it's one other tool, the same way you would get a family history, the same way you would, get a dose medications based on renal dosing or hepatic dosing. It's the same type of thing with pharmacogenetics. If you're using only a genetic profile to make a clinical decision, you're doing it wrong. So it's just something to add to everything else a provider already knows. And right now, we live in a world where PGX does a better job at predicting tolerability to medications than identifying the perfect medication. So my chief medical officer often jokes, this is not the Academy Awards. We're not going to open up an envelope and say, here's the perfect drug for you. What we're going to do is try to narrow down the range of medications so you optimize your choices and you optimize your dose. There's about 30 antidepressants that a provider can choose from. Someone comes to you with depression, you have lots of options. Well, how do you minimize all of those options down and really personalize it? That's what we're trying to do here. Okay, so again, pharmacogenetics, the principle here is that one size does not fit all. If you ever opened up a drug label, an FDA drug label, you would see some type of dosing. And that dosing is just an average dose based on everyone who was in that clinical trial. Okay, hundreds of people were in that clinical trial, and the manufacturers determined an average dose. But while this dose works for the average person, there's a lot of variability within that average, and it doesn't take into account the people who can't metabolize certain medications or the people who hyper metabolize certain medications. So I'll give you an example. One of the most commonly prescribed antidepressants is Lexapro. You've probably heard of it before. So standard dose of Lexapro, start someone on 10 milligrams, maximum dose of 20 milligrams. That's average. But about 2% of the world can't metabolize Lexapro. So that starting dose, that 10 milligram starting dose in that 2% feels more like a 15 or a 20 milligram. But it's not taken into account unless you know who those 2% are. And I'm actually making a common flaw here. I'm saying 2%, but that 2% is a global average. If we isolate our groups a little further and we select just East Asian patients, Well, 13% of East Asian patients can't metabolize Lexapro. So that's a big chunk of the population that's getting higher blood levels of a very common medication if you dose them like you dose the average person. On the other end of the spectrum, there are people who are fast metabolizers, rapid or ultra rapid metabolizers. That's actually more common. 20%, 30%, up to 40% of us can be fast metabolizers of this drug Lexapro. And if you are, that's going to decrease your blood levels of certain medications. Okay, but currently, standard of care is you don't take that into account. You just give the average. What we're trying to do is look for all the variability within that average and then personalize your dosing. I'll give you another real world example. This gene that metabolizes Lexapro, it's called 2C19, CYP2C19. Maybe you've heard of it before. It's not important, but this very same enzyme metabolizes something called Plavix. And I imagine if we have enough people on this call, somebody on this call is taking Plavix right now. It's the world's #1 blood thinner, prevents stroke and heart attack. Now, remember I mentioned earlier, up to 13% of East Asians, Pacific Islanders, Koreans, Chinese, Japanese, up to 13% can't metabolize Lexapro and can't metabolize Plavix. And in those people who can't metabolize Plavix, there's a higher risk of treatment failure. You're more likely to get a heart attack or more likely to get a stroke. And there was a lawsuit, it was either last year or the year before, where the state of Hawaii ended up suing the manufacturer of Plavix because there's such a high population of Pacific Islanders and East Asians in Hawaii. And the state claimed that the manufacturers of Plavix didn't put sufficient warnings in their FDA label about the risk for these poor metabolizers. Okay, on average, it's only affects 2% of the population, but in Hawaii, it was up to 10 to 13% of the population. And the state ended up winning this lawsuit. And now, if you look at the FDA label of Plavix, you'll see there is a warning for those who are poor metabolizers of this 2C19 gene. So this technology has been around for 30 years, probably longer than that, probably 40 years. And it's not until recently that it's starting to get implemented, and it's still not standard of care. But in maybe 5 years, maybe 10 years, I don't know how long it's going to take, but eventually it will become standard of care. So again, what are some of the common problems we see with medication management today? Okay, so up to 50% of patients are non-adherent to medications. I guarantee you the drug that doesn't work is the drug that patients don't take, and non-adherence is a big problem. There is some evidence and some evidence that we published showing that pharmacogenetic testing increases adherence rates. Okay, if anyone is interested in this, I can send you these links to the literature. But one of the goals here is to increase adherence. If we can prescribe drugs that are more tolerable, people are more likely to stay on them. So that's the top left. If you look beneath that, you can see 528 billion spent annually on drug-related morbidity and mortality. Well, how can we reduce that? And then if you look at the top right, you'll see 3.2 million hospital and emergency room visits are due to adverse drug events every year. We published a paper where we looked at in the Aetna database, and we compared people that used genetic testing to those who didn't use genetic testing. And the ones who were tested had a decrease in emergency room visits and a decrease in hospitalizations. And that led to about a $2,000 decrease in utilization, decrease in costs in the first 6 months. And then going back to this morbidity and mortality question, our company, Genomind, focuses a lot on psychiatric pharmacogenetics. Some of our genes are universal, but our specialty is in psychiatry. And I mention that because depression makes every other disease state worse. So if you have heart disease, depression makes it worse. If you have cancer, depression makes it worse. Asthma, pain management, whatever the case is, adding a depression diagnosis on top of that makes the outcomes worse, and it makes these patients more expensive. And I mention that because some of the best evidence to support pharmacogenetic testing is in the depression space. There's 2 meta-analyses and some pharmacoeconomic evidence to support its use in depressed patients. Okay, and then if you look at the bottom right quadrant over there, you can see 52% of outpatient drug reactions are deemed to be preventable. So here's the problem. I'm not claiming that PGX is the solution to all these problems, but it's something that can help each one of these problems. Okay, so if we look at the older patients that are in the long-term care space, some of these risks, some of these medication management risks are amplified. Okay, so 60% of those in nursing homes experience adverse drug reactions. Look at that bottom metric right there, the last bullet point, which says 91% of long-term care residents take 5 or more medications, and 65% take 10 or more medications. Once you're on 10 or more medications, you're almost guaranteed to have some type of drug-drug interaction. Okay. We did an internal analysis where we found that it's right around 7 or more medications. So we looked at a couple of databases, some pharmacy databases, and the ones that were on 7 or more medications had over a 95% chance of being of having a moderate or a major drug-drug interaction. Okay, so this may sound like a ridiculous amount of medications, 10 or more medications, but in nursing home residents, this is actually the rule and not the exception. Okay, I'm going to check the chat for a second. Oh, that's just some housekeeping stuff, so I'll keep going here. All right. I mentioned earlier that pharmacogenetics is just one tool, and we can't rely only on pharmacogenetics when we're doing medication management. We have to look at other things. We have to look at drug-drug interactions as well as drug-gene interactions. We have to look at family history. We have to make sure our diagnoses are correct. One of the things we need to look at also from a population health standpoint is who are the best candidates for this type of testing. It's a question we get all the time. We get it from payers. We get it from large provider groups. They say, we're not going to test everybody. We don't have the bandwidth to test every one of our patients. So who should I test? What's the sort of ideal candidate for this? Well, we heard that question so often, we built software and a population health stratification tool to help answer that question. What you're looking at here is the output from that tool, the output from that software. So if you look along the bottom axis right there, these are different risk deciles. So if you're starting from the far left, you can see on the bottom it says 0, 10, then 10, 20, 20, 30, etc. So the first one, these are the amount of people in this cohort that had a 0 to 10% chance of a significant drug-drug gene interaction. All right, so we built this software that assesses a population for drug-drug interaction risk, but also estimates the drug-gene interaction risk for that population. Okay, and we can do this because we know how frequently these genes occur in the population, and we know how frequently they occur with different ancestry groups. So if we knew the precise ancestry and ethnicity of these cohorts, we can fine-tune this even further. So if you're looking from left to right, and you have a bunch of patients, I think there's about 3,000 patients in this cohort. If you had limited resources and you say to me, who am I going to test? Who are my best candidates? Who should I focus my resources on? Are you going to spend your time worrying about those individuals that have a 0 to 10% risk of a significant interaction? Or are you going to focus your time on those in the gold box on the far right who have a 70 to 80% risk, 80 to 90% risk, and 90 to 100% risk of a gene drug interaction? And what we've done with most of our partners, once we look at this, at their patient profile, their medication profile, we'll say, let's focus on those in this 90 to 100% risk category. And in this example, it was 487 patients out of about 3,000. Okay, and that's much more palatable to say to a payer or a large provider group, we're not going to test everyone, but why don't you focus on this, whatever it is, 15%, 20% of your population. And this is where you get the most bang for your buck by doing a drug-drug interaction analysis, but also getting these people pharmacogenetically tested because they're on medications that have it, and their expected genetic profile falls into this high risk bucket right here. So again, you can't use PGX in a vacuum. You have to use all these other tools. You have to know who to test. You have to, everything we do has either a pharmacist or a pharmacologist, a PhD pharmacologist driven analysis. So we don't just throw this data at our providers and say, good luck, figure it out. We hold everybody's hand to walk through this until they're comfortable with it. And once they get comfortable, they see the advantage in here. And at least in some of our partners, they're starting to see decreases in costs already. All right, so moving right along here, let's talk a little bit about who's paying for all of this. So, this technology, like I said, has been around 35, 40 years. Not until the last maybe 7 or 8 years has there really been a lot more focus on it. Until recently, there were really no third-party providers paying for it. But then last year, or maybe it was 2020, Medicare issued a local coverage determination, basically a billing policy for pharmacogenetic testing. Okay, and Medicare basically said, if you are a Medicare recipient and you meet certain criteria, then PGX testing is considered reasonable and necessary. Okay, and they will reimburse for this type of testing. So, obviously the next question is, well, what are the criteria that need to be met in order to be eligible for pharmacogenetic testing? Well, I have to give you a little background before I tell you what the criteria is. There are, in addition to the FDA, there are research groups, research consortiums that publish these peer-reviewed guidelines, peer-reviewed pharmacogenetic guidelines. If you've never heard of CPIC before, CPIC, that's an international consortium of researchers, and they publish these guidelines. I think there's 26 of these guidelines right now. These guidelines include antidepressants, ADHD medications, cancer medications, cardiovascular meds. So 26 of them in total. And if a medication has one of these CPIC guidelines associated with it, that's considered reasonable criteria to approve testing for a Medicare patient. Okay, so there's really two or three criteria that need to be met. A clinician or a provider first has to assess the patient without taking any genetics into account, and have a drug plan in place. Okay, so at this point, they haven't even thought of genetics. They've just looked at the patient, looked at the symptoms, and created a potential drug plan. Based on that drug plan, if these medications have FDA guidance, FDA genetic guidance, or one of these CPIC guidelines, then that person is eligible for pharmacogenetic testing. Now, this is probably the vast majority of Medicare recipients, because the medications that we're talking about here are beta blockers, which are really common. Acid suppressants, things like Prilosec and Nexium, some common gastrointestinal medications, SSRIs. So if you're on Medicare, and the average Medicare recipient is, I think, on about 4 or 5 medications, chances are pretty good you'll be on one of these medications that has one of these FDA or CPIC guidelines, or your provider has to be considering one of these medications for you. And if you meet that criteria, that's considered reasonable and necessary to cover PGX testing. So why is this such a big deal? Everyone usually follows Medicare's lead. It's this same type of testing is covered in some state Medicaids. Not every state Medicaid, but I think there's like 36, 38 states where they'll cover pharmacogenetic testing when similar criteria is met. There are some private commercial plans that have coverage policies in place and a very similar type of criteria that need to be met in order for it to be covered. But this is a big deal because once Medicare has a policy in place, then the dominoes start to fall, and we expect to see a lot more coverage for this in the coming years. Okay, so I talked a little bit about CPIC. Let's talk a little bit about the FDA right now. So the FDA's stance, the FDA's legal stance on pharmacogenetics is that the FDA has the authority to regulate laboratory developed tests. That's what all pharmacogenetic testing is. It's a laboratory developed test. The FDA has the authority to regulate laboratory LDTs, laboratory developed tests, and they will use their discretion to regulate. Now, there's a couple of congressional bills out there. One is called the Valid Act. One is called the Vital Act. They're sort of competing bills. But these will really better codify what the FDA's authority is to regulate these types of tests. Currently, this is the FDA's formal stance. If you look at the bottom of this box right here at the bolded section, indeed, genetic testing can enhance patient management by improving the selection of medications or the dosage of a medication, tailoring the therapy to the patient. But the caveat is, but only when it is based on sound science. Unfortunately, there's some labs out there that were doing some genetic testing without proper provider approval, and using genes that didn't have sufficient evidence. And the FDA took notice, and they sent out some warnings a few years back. Since then, the FDA has been relatively supportive of pharmacogenetic testing. They've launched a FDA table of pharmacogenetic biomarkers. They've also launched a FDA table of pharmacogenetic associations, and they're working with some pharmacovigilance groups like Stripe to work through any issues they see with pharmacogenetics right now. So in recent years, the FDA has been largely supportive of pharmacogenetics. And if you look at the FDA labels, there's about 300 medications that have some type of FDA guidance or warning in the actual label. Celexa, a common antidepressant. Codeine, everyone knows what codeine is. Abilify, a medication commonly used for depression and bipolar and schizophrenia. Dozens of medications, hundreds of medications actually, that have some type of pharmacogenetic guidance in the FDA label. Here's an example of some of them. So amitriptyline, one of those older antidepressants, has in the precaution section of the FDA label, they speak specifically about this enzyme called CYP2D6. It's a drug metabolism enzyme. And if that enzyme is deficient, it increases the side effect risk for amitriptyline. Beneath that, you have a medication called atomoxetine. It's used for ADHD in children and adults. There's a specific dosing guideline in the label, both a pediatric and an adult dosing guideline for the same gene, for this 2D6 gene. Amphetamines, those are the other medications that are used for ADHD, both in adults and children. Probably familiar with like Adderall and Vyvanse, things like that. But there's in the clinical pharmacology section of the label, it mentions the CYP2D6 gene and how that can influence blood levels. Aripiprazole, a medication I mentioned earlier that's used for depression, bipolar, schizophrenia, autism. There's very precise dosing guidance in the FDA label. It'll say, and very specifically, it says, if you are a poor metabolizer, cut your starting dose in half. And if you are a poor metabolizer and you're on this medication, cut your dose by 75%. So very precise dosing guidelines in this era of precision medicine. And again, this is another quote from the FDA biomarkers table. Pharmacogenomics can play an important role in identifying responders and non-responders to medications, avoiding adverse events, and optimizing drug dose. Just recently, maybe a month ago, maybe 3 weeks ago, we came across this announcement from the NHS out of England. So the British Pharmacological Society made a recommendation to the NHS, and the recommendation was basically pharmacogenetic testing should be available to every British citizen out there under and covered by the NHS. Not long after that, NHS published this announcement. You can see the links down below there. Basically published an announcement, and the head of the NHS, and I'll highlight the bolded parts here. So pharmacogenomics must be available to everyone. This is the head of the NHS. It is now mainstream. It is the future. It can now help us to deliver a new, modern, personalized healthcare system fit for 2022 and not 1948. And 1948 is when the NHS first came into existence. So you can see a huge American agency, Medicare, has a coverage policy in place. The FDA has a lot of information related to pharmacogenetic guidance and dosing. And now you have the NHS essentially endorsing pharmacogenetic testing for every British citizen. And so I think we've reached an inflection point here where this is going to start to become much more mainstream. And at some point it will become standard of care. Now, I'm not a gambler, so I don't know if that's going to be 3 years, 5 years, or 10 years, but I think we'll get there. Okay, let's see. We have a question in the chat. Do you have links to the Medicare policy? I do. There is a MolDX local coverage determination. I will find that, and I will either post it in the chat or I will forward it to my friends here, and they'll make sure you get it. But if you, in the meantime, if you Google MolDX Pharmacogenetics LCD, you can find it that way. But I'll provide the link also. Okay, so I mentioned earlier all the different tools that we use when we do pharmacogenetic testing. So there's there's managing drug-drug interactions, there's managing drug-gene interactions, there's getting the diagnosis right, family history, environmental modifiers like smoking and coffee and grapefruit juice. How do you manage all this stuff? How do we expect a provider to keep all this stuff organized? Well, it's impossible. We do it for a living, and me and my team does it for a living. We're pharmacists and PhD pharmacologists, and we struggle with it. So we built software to help manage all of these possible interactions. Originally, we built it internally for us to use to help educate our providers, and then it was so successful we launched it, and now it's a product and service that we offer with alongside our pharmacogenetic testing. So at the end of this presentation, it looks like we're going to have enough time, but what I want to do is actually go through a demo of what this software looks like. You know, how you can enter different medications and how different genetic profiles will influence these different medications, and then show you also how it takes environmental modifiers into account. It's a tool better. I'd rather show than tell. So let me get through the slides and I'll do a demo of that. I mentioned earlier that our test, our PGX test, focuses mostly on psychiatric gene-drug associations. That's not entirely true. About half of our genes are universal. They apply to all disease states. About the other half of the genes that we test for are related to psychiatry. And more specifically, we have genes related to depression and anxiety treatments. We have genes related to bipolar and schizophrenia treatments. There are certain medications that are known to cause significant weight gain. We have genes associated with that weight gain risk. Some people have genes where they're more likely to gain weight on medications, and some of us are lucky enough to have a protective gene, which reduces our risk of weight gain with certain medications. We have genes in our report related to ADHD drugs and their metabolism. We have genes related to opioid sensitivity. So remember earlier I said there is a black box warning for codeine in the FDA label and for tramadol in the FDA label, two commonly prescribed opioids. And we have a gene that will basically say, hey, don't use these medications if you carry this gene, because your risk of respiratory suppression is so much greater. Genes related to treatments for alcohol abuse, and then lastly, some medications can cause significant skin reactions. I don't mean a mild rash. I mean a life-threatening skin reaction. Things like Stevens-Johnson's rash and Dress syndrome. These are life-threatening rashes that can occur with certain medications. And if you carry a certain gene, you're about 10 to 100 times more likely to develop these rashes. These would be considered contraindications, these skin reactions, because the risk is so severe. Here's another way to sort of visualize all the different genes that we look at. If you look at the left side of this screen, these are genes that affect your drug metabolism. Do I break a medication down quickly, or do I break it down slowly? Do medications get into my brain quickly, or do they have to struggle to cross into my brain? Those are all the genes on the left. You'll never have to remember this, but those are called pharmacokinetic genes. Kinetic meaning motion. How quickly do you get rid of a drug? How quickly does a drug get into your body or get out of your body? And then everything on the right is what we would call a pharmacodynamic gene. These genes don't affect the blood levels of medications. It doesn't affect how quickly a drug gets in or gets out of the body, but they are genes that affect sensitivity to medications. Are you more likely to gain weight on medications? Are you more likely to get gastrointestinal side effects with a medication? Are you more likely to get a skin rash with a medication? All things that the pharmacodynamic genes try to account for. And notice the way I'm saying that, more likely. This is like every other branch of medicine. It's risk assessment. So, we very, very rarely are there absolute contraindications when we look at a person's genetics. There's some, but those are the exception. Most of the time we're doing a risk analysis and saying, you have a higher risk of this. Is there an alternative, or can I mitigate that risk by changing the dose? Okay, I mentioned CPIC earlier before also. This is this international consortium of researchers. I just want to show you an example of what some of their guidelines look like. I mentioned the medication Lexapro when we first started here. It's one of the most commonly prescribed antidepressants. And there's a guideline for all the different flavors of gene you can have. So if you start from the top left here and work your way down, you can see there's a guideline for ultra rapid metabolizers, extensive metabolizers, that means normal, a guideline for intermediate metabolizers, and a guideline for poor metabolizers. And in some cases, these guidelines are very specific. For example, ultra rapid, consider an alternative drug. Okay. 2C19 poor metabolizer, consider a 50% reduction of your starting dose, or consider an alternative drug. So these guidelines are getting very specific, and there'll probably be another 2 guidelines published either the end of this year or early next year. Okay, so now I'll talk a little bit more specifically about what it is we do here at Genomind. So again, there's sort of 4 pillars to what we do. Talked a lot about pharmacogenetic testing, and that is the main pillar. So the core feature of our precision medicine platform is doing the actual PGX testing. We get the samples from patients. The test always needs to be ordered by a prescriber. Okay, so patients can't do this on their own, because we don't want patients managing medications on their own. So you need a prescriber involved to order the test. And when they do order it, we usually get the results back in about 3 days or so. Provider gets the results. We always encourage a clinical consult. So if it's a new provider, we will proactively contact that provider and say, do you want to do a consult with our clinical team? We can help you interpret the report, explain what all this nomenclature means, walk through treatment algorithms, whatever the case is. It's important to provide this education, because if you're over 45 years old, you have probably had no pharmacogenetic clinical training in your medical career. In fact, they're just starting to implement it in medical schools, pharmacy schools, and nursing schools now. So we offer the PGX testing, and when we provide a report to the provider and the patient. With that comes the decision support software. So that's the drug-drug and drug-gene interaction software. That was always intended to be used at the point of care, at the point of prescribing. But we've taken that software, we've taken that engine and turned that into a population health tool. And instead of using it just at the point of care, at the point of prescribing, now we can use it with large cohorts of patients. We can take a file from a partner. That partner could be an accountable care organization. It could be a provider group. It could be a payer. We'll take a medication file from them. We'll run it through our software engine, and then we'll stratify all those patients. Remember those buckets, those risk deciles I was showing you earlier? We'll put patients in different buckets of risk, and we'll say, put a clinical pharmacist on this group. They have a high risk of drug-drug interactions. And here's the group that are good candidates for pharmacogenetic testing. So it's a population health service. And then I touched on this earlier, but clinical support and education, it's incumbent on us to make sure providers are using this technology appropriately. We provide all clinical guidelines and FDA guidelines to providers. We provide a level of evidence for all these drug gene associations, and we do a lot of hand holding with clinicians that are new to this type of testing. So those are the 4 pillars that support what we do. Okay. Here's a sort of well, we call it a snapshot. So here's our snapshot, which is part of our population health tool. So the way the snapshot works is this is unique for a patient. We would look at a file of 1,000, 2,000, 10,000 patients. And then for every one of those patients, we would generate one of these snapshots. And then the provider would get this snapshot. It would identify any drug-drug interactions, and it would flag them as moderate or major. And then it would predict their risk of drug gene interactions. So if you look at this sample report that you look on the right here, you can see this is someone who currently has a moderate drug-drug interaction. Okay, this person's taking metoprolol. Because of another drug they're taking, metoprolol levels are going to be amplified. Here's some possible alternatives to minimize that drug-drug interaction. Okay, so we've identified something we know. This person faces a drug-drug interaction. But in reality, there's a 49% chance that this is actually a major drug-drug interaction. That's the chance that they have a gene that will turn this moderate interaction into a major interaction. Okay. Depending on who the partner is, they may consider this person a candidate for PGX testing, depending on where they set their threshold. And then once tested, this box would go away and we'd be able to assess their true risk, their true pharmacogenetic risk, as opposed to their risk estimate, which you're looking at here. Okay, so looks like there's some questions in the chat. I'm going to answer them, and then I'll try to demo the software for you for a minute or so, just so you can see how prescribers are using it. Okay, so Medicare policy, we touched on that. One site where you can find all the state Medicaid policies. If you find it, let me know. I don't, nothing is easy with Medicare and Medicaid. So if there's one source for that, kudos to you. Okay, this will be posted to the Weddy site later today. So thanks, Samantha. Does the probability of risk take any baseline information like ethnicity into account? So it can, yes. What we found with most of our partners is that they don't, EMRs, electronic medical records, don't do a great job of capturing ancestry or ethnicity information. So we've built the software where if we have that information, we'll plug it in and we'll get a more precise risk estimate. Most of our partner files don't include that information. It's something we've requested, but the EMRs don't really do a good job at capturing that right now. So Sandy, hopefully that answered your question, but if not, you could add something to the chat. I'm gonna actually stop sharing for 1 second. I'm gonna try to pull up the software here. And of course I timed out, so let me refresh the software. And now I'm gonna try to reshare. Okay. So Rosalind or Samantha, give me a thumbs up that you can see this precision medicine software.
Yes, I can see it.
Okay, good. So I am sharing correctly. This is what the software looks like. You can see there's a box here to enter different medications. Here's a gene profile on the right here. Right now, everything is set to normal, but I'm going to modify this gene profile. I'm going to make this person a poor metabolizer here and a risk for skin rash here and an interaction with smoking here. So now you can see I've changed the genetic profile of a patient. A provider would never need to do this. So all the genetic profile would be pre-populated after they test. But for demonstration purposes, I've created a genetic profile. If I were to add a medication in here, I'll use one of the older antidepressants. Actually, let me go back, and I mentioned the medication Abilify before, used for depression, bipolar, and schizophrenia. You can see that if I want to start a patient on this medication, the software would say, hey, this person will have increased blood levels, and this is a high-risk interaction. It's a major problem because blood levels will be amplified significantly in this person. So what do I do about it? Well, I look at the PGX guidance tab, and this will include any guidelines from the FDA label or from CPIC, that international consortium I talked about, or another European consortium called DPWG. Okay, so the FDA label has some very specific guidance. Administer 50% of the usual dose. And by the way, administer only 25% of the usual dose if they're a poor metabolizer and they're on another certain other medications. So that's the FDA label. The European guideline takes a step further and says, don't give any more than 10 milligrams per day of this medication. For the injectable version, don't do more than 300 milligrams per month. And you should be about 67 to 75% of the standard maximum dose. Okay. So there's very specific guidelines for dosing if you want to adjust the dose based on the genetics. But there's also an alternative medications checker, which will rank medications in the same family based on their level of risk. So if we click this, you can see these are a bunch of other drugs in the same family. We'll present the low risk options first, and then you can see here some high risk options down here. So if we were going to switch this medication to something else, we're not going to switch it to these equivalent high risk options. If appropriate, we're going to select one of these alternatives here. And maybe we like this medication, we just swap it out, and now we have minimized a major drug gene interaction. Another thing we can look into, let's say we were considering a medication for bipolar. Here's a medication called Tegretol. This would be considered a contraindication. Do not initiate. Increased risk of skin reactions. Contraindication. Here are some alternatives that would not be considered contraindications. In addition, it takes environmental modifiers into account. So here is a medication that's a muscle relaxer. It looks pretty clean right now, no major interactions. But if your person is a smoker, you can see you're now presented with a moderate interaction because the blood levels of this will get suppressed. So I just wanted to show everyone this just to get a feel for how this is being used in clinical practice, how clinicians are working through all this information. And now I'll go back to the chat to see what we have. Okay. Okay, input data about treatment suggestions. Would you rely more on identified or de-identified data for pharmacogenetic treatment suggestion development? All of the data we receive for our population health analysis is de-identified, okay? When we send the output files to a provider, those snapshots that I showed you, those are then re-identified. So, a provider needs to know what patient they're talking with. So everything we receive is de-identified. It's assigned a patient number. When it goes back to the providers, we re-identify it, and then we'll consult with that provider or do a drug analysis with that provider based on the true patient information. Not sure if that answered your question, but if not, let me know. How will pharmacogenomic processes address new information, for example, SSRIs, SSRIs in the recent study states a comprehensive review of major strands of research on serotonin shows there's no convincing evidence that depression is associated with cause, but I mean, we've known for quite some time that the serotonin hypothesis for depression is a flawed hypothesis. Depression, SSRIs work, and they work partly because of their change in serotonin, or the way they modify serotonin, but only about 40 to 50% of people will respond to an SSRI. So clearly there's something else going on other than just this serotonin hypothesis. It is very likely inflammation. It is very likely deficiencies in other metabolism errors like methylfolate metabolism. There are multiple different explanations or theories for what causes depression outside of the serotonin hypothesis. Our team reviews the literature on a weekly basis, and then we make updates to our report on a quarterly basis, and we review all the guidelines on a quarterly basis to make sure we're current with them. Turnaround time, the testing and incorporation of this info into the system. So the turnaround time for the actual testing is about 3 days, 3 or 4 days. So if a physician wants to start treatment but wants it to be guided by PGX, how long do they generally have to wait to begin treatment? Well, it depends on the severity of the patient's symptoms. If you have somebody acutely suicidal, you're not going to wait for a PGX test before you start therapy. But if it's mild to moderate depression, we do have clinicians that will wait for the PGX results before they initiate therapy. But that question, one of the solutions to that question was addressed by the NHS, and the NHS said if we did universal pharmacogenetic testing, that answers the question about how long do you wait? Because ideally, if you did preemptive testing, everyone would have a pharmacogenetic profile in their electronic health record, and then before you prescribed anything, you would access the health record. And so, the good thing about pharmacogenetic testing is it's a once in a lifetime test. While the genes will never change, how we interpret these genes may change, but the data itself is with us forever. Maybe I have time for one other question. We're at the top of the hour. Different data types of data used. You use clinical EHR claims, prescription, labs, or behavioral data. So we're not getting any behavioral data right now. When we work with our partners, that's done after the results are received. But yeah, we have looked at, we've worked with pharmacies and we've captured their pharmacy prescription data. We've worked with accountable care organizations and they'll send us their EMR data. We've worked with provider groups and they'll send us the EMR data. So yeah, we have a spec for the data feed that we need in order to turn around the results, within a couple of days. So Rosalind, I think that brings us to the top of the hour. So maybe I'll pump the brakes here and see if you have any closing comments.
Well, I just wanted to say thank you. There's a lot of comments that are popping up in the chat that people have enjoyed this. Once again, I am extremely impressed. You absolutely know your stuff, and I think you bring it to us in a way that is understandable for people that may not be clinically technical, which I think was the point of why we wanted to do this. So Dan's information was out there for anybody that wants to contact. I put my email into the chat. If there's any follow-up discussions anybody is interested in having, please feel free to reach out to me. And once again, Dan, thank you so much. This was amazing.
Thanks, Rosalind, for hosting this. My email's there. If anyone has any follow-up questions or I didn't get a chance to answer your question, feel free to email me, ddowd@genomind.com. Thanks again, Rosalind.
You're welcome. Bye, everybody.
Bye.